Thank you, Ed, for that very, very generous introduction. And I must say, given all the years I've known you, there couldn't be a better man at the right time in the right place doing the right work. And thank you for the Beaumont Foundation. I've actually had Don out twice to Michigan. I've had Denise Koo out 3 times to Michigan in the last 2 years since then I've been there as dean. So it was only appropriate that I reciprocate. So it sounds like from my introduction, people already have my number. Relentless, actually, what Ed wanted to say was provocative and inappropriate. And Lloyd said, fasten your seatbelt, and that was framed better by Leslie, who said, Ollie, you're going to do 41 slides in 30 minutes. Absolutely. So we don't have a whole lot of time for chit-chat to start off with. My instructional designer advises me you should always start with something different from your talk with your audience. Her favorite is a goldfish has 3 seconds of attention. No idea why she likes to start with that, but I like to start with something a little bit more provocative, right? So my apologies, Ed. You said leave the tweets at the door. I didn't start this with hashtag Kofke, and what does that really mean? But what I'll do is I'll start with something provocative, right? And this is the president's budget for major public health agencies. And you'll see the cuts that are slated for Health and Human Services, for Environmental Protection Agency, and for labor. And this interesting quote, the proposed budget would force CDC to fight epidemics and health threats with both hands tied behind their back while wearing a blindfold. So this is the environment that we are working in, and I'll go over this in a minute, a little bit more. These are standard learning objectives. And let's see if I can get this. Okay, so we're going to start off with is the state of our health. I'll talk about academic-private partnerships and that specific practical part about what we do, the changing landscape of health and successful new models, and finally I'll leave you with a little call for action. So this should be hopefully a quick review for people here in the audience, which is what is the state of our health? And there's a number of different ways to frame this, but what I'd like to do is instead of taking the public health and the healthcare perspective, let's take your perspective in this audience in your community, right? And what is your perspective? And this is what I've been taught as a dean. This is the perspective of everybody you talk to, right? This is what matters to them. Right? What am I paying for health care is the first thing that matters to them. We'll work a little bit later on broader health issues in a community besides health care. This is a snapshot to show you what some of the proposed increase in premiums are this year. I recognize that this is the marketplace. There's also employer plans. It's different in different states. Whether this is due to a death spiral or whether it's due to fundamental efforts to prevent the full implementation of the Affordable Care Act, I'll leave that to you and your personal politics. The point is, this is what the people you talk to every day in your communities, this is what's on the back of their mind. And this shouldn't be surprising to you, because healthcare costs a whole lot in the United States, right? So it's a $3.2 trillion industry if we look at healthcare spending itself. And this healthcare spending, as you know, markedly outpaces wages and inflation here in the United States. And despite this cost, and I'm sure many of you, if not all of you, have seen this slide, despite the cost of healthcare in the United States, we don't get the best health outcomes. And I'm going to make that differentiation between health and health care. We don't get the best health outcomes when we think of life expectancy, infant mortality. There's been a lot of papers recently about actually maternal mortality and what maternal mortality looks like in the United States. Also, despite this cost, we failed to cover and provide insurance for everybody in the United States. There's still approximately 30 million people who are uninsured in the United States. Despite the market success we've had since the Affordable Care Act, we actually have the lowest number of people uninsured ever in the US at this point. Now, this slide breaks, if at first glance, breaks every rule about slides because you have no idea what's going on. But it actually gets the primary rule of every slide. And the point is that there is no way to understand what's going on when we look at the size of hospitals, the quality of the care you get, the patient satisfaction, completely independent for most purposes. And Arcadia Health Solutions does this wonderful job of looking at big data for healthcare and combining that. But this is a really great example of the fact that you can't sort of track those on a line. Large hospital, academic hospital, great patient care, great patient satisfaction. It doesn't happen. This slide also does tell you actually in the fact that this weave that you see is there significant inequities and inadequacies in our healthcare system. So our healthcare system is potentially the third leading cause of death in the United States. And we also fail to provide adequate care. Many of you, I'm sure in this room, work on the Million Hearts campaign or know of the Million Hearts campaign, and how many people actually with known documented hypertension in their chart are not treated. Okay, so, and then of course all the other inequities, inequities in care. For example, if you're an obese physician, what is the likelihood of you to tell an obese patient that they should lose weight? So lots of inequities in the health care itself. But there's also inequities in health. And let me show you here in my own city of Omaha, my new adopted city is the last 3 years. So, and I could draw this graph for any of your communities here. So this is a city of about 750,000 people. I think our MSA is approaching about 1 million right now. I can go a distance of 20 miles in Omaha, 20 miles with a 12.5-year life expectancy in those 20 miles. Completely unacceptable for us as a nation, I believe. The California Endowment has done some of the best work to sort of highlight these inadequacies in health. Healthcare being a part of that, but inadequacies in health and these discrepancies that you see, and this is their example of whatever 15-year life expectancies between two zip codes, and they like to say that your zip code is a better predictor of your than your genetic code of what your health's going to look like. But I want you to all think about disparities very differently, because I believe how we've been viewing disparities is inadequate. This zip code thing doesn't, and often this takes you right to socioeconomic status, obviously. It's not an accident that the two kids look very different from each other. But what does that tell you about disparities we're seeing in LGBT care in the United States? All right, what does that tell you? This is a little busy, but it's to make a point about disparities in the United States. So the first 3 slides, top right, Canada, England, and is it Canada and England? And the first 2 is Canada, England, and Wales. To orient you, the center line means no change. And if you are to the left of the line, it means you're getting better. If you're to the right of the line, it means you're getting worse. Men and women in blue and red going up the little snake. And essentially, if you look in Canada and England and Wales, they have a 3% decrease, a 3% improvement in life expectancy over this time period, 1999 to 2014. What we should be seeing, right, in developed countries. We should be seeing that our life expectancy is getting better. And then it's also true for the United States, almost for every age group. But then if you say, okay, let me look at my data, which you're all very good at, let me blow up my data in the US and see what happens. And what you'll see that for the most part in the US, and I think the best one is Hispanics and blacks, so that's F and G. You'll see, yep, doing much better. They are on the left side of the curve, doing much better. Asians doing much better over that 15-year period. Not so true, E, this is bottom left, for American Indians and Alaska Natives, wrong side of the curve, life expectancy going down. But what's most interesting is if you look at whites in the United States, and you'll see that white males and white women at this 20 to 34-year age group, they're on the wrong side. So life expectancy actually is going down for this age group, especially for women. So I love to ask my friends who are in disparities, who's ready to go out there and fight for white women between 20 and 34 years of age for their disparities? And they look at me, they go, wait, that's not our business. Yes, that is your business. That is the health business, to address each and every one of these disparities and try to understand why do we have those disparities. And why we have disparities, hopefully everybody in this room recognizes this slide, right? This is right out of your practical playbook slide. And the reason for these disparities is health care So after you wipe out the genetic causes, this is sort of a pie chart of what leads to health. And healthcare is such a small proportion of what leads to health, right? And if you look, I love, the counter slide to showing how life expectancy is in these high-income countries is what we value in high-income countries, health compared to social services, and how there's this discrepancy in the United States where we have the lowest ratio of spending for health care to social services. And that sort of explains why my guess is each and every person in this room is in the social determinants business. How do you approach health, not just from the top-down approach of Mr. Johnson has high blood pressure and Mr. Johnson needs to lose 20 pounds, to the bottom-down approach to Mrs. Susan we need to make sure she has a safe neighborhood she can walk in and make sure there's more options for her than Twinkies at the local store, right? So how do you do the top-down, bottom-up? You squeeze them in the middle and you get health out of the system. Okay, so that's a synopsis of slide one. Before I got into the dean business, I used to say healthcare is fundamentally broken in America. I no longer say that. I say healthcare is the most beautifully designed system ever seen, designed to do one thing, and that one thing is make money. It's beautifully designed to do one thing, make money. Patient's not in that middle of that. It's designed to make money, and it does it really, really well. So let's talk about how academic and private partnerships can address some of these issues. So when I became a dean, I asked the question, I'm not sure you're allowed to ask this question, why are there 100 schools and colleges of public health, right? That wouldn't work. I mean, but unfortunately, the way higher education is structured, the University of Minnesota, my good dean is here, doesn't go, you know what, we're doing a great job. Let us just, buy out the University of Nebraska or the University of Arkansas. It just doesn't work. So if we have to be in this business of public health, we decided that business needs to be around improving the health of the state and making Nebraska the healthiest state in the nation. And what did that mean for partnerships? We're currently ranked 12th, and we've had some strains around low drug deaths, et cetera, but we have a lot of challenges around obesity and excessive drinking and pertussis and other things. And this, you can get this right out of the United Healthcare Report. That's sort of the metrics we use for the healthiest state in the nation. And here are two examples of things that we've worked on collectively for the state, bringing our healthcare partners, our public health partners, and our community together. And being an academic health center has allowed us to bridge all of the partners within the community. We're actually ranked 42nd in the nation for binge drinking, which is really unfortunate. I'll leave the statistics for binge drinking to you. What I wanted to point out in this slide and the next slide, besides what we ended up doing screening, brief intervention, referral for therapy. It's something that the healthcare system can bill for, so it got everybody on the table. But the only thing that's important for my two slides is actually the logo on the bottom right. That logo, you will notice, is not the logo I'm wearing on my coat, okay? The logo I'm wearing on my coat is University of Nebraska Medical Center. The logo on the slides is Catholic Health Initiatives. So this is the other large health system in Nebraska. And because we were an academic health center, it was easy to bring all of the health systems together to say, oh, we want to work on this together. And we're hoping within the next year, essentially, every clinic and hospital system in Nebraska will be using SBRT as a way to try to address binge drinking within the state. So the only thing's important is the logo. And then we're also working on policy-related issues. This is out of the prevention status report to sort of link the healthcare part to the policy part. The second thing is colorectal screening. We're 41st in the nation in colorectal screening. So we laid out saying that how do we get 80% of the country of Nebraskans screened by 2018. Again, this is a low-hanging fruit, right? All of the metrics, as we think about ACOs, et cetera, include colorectal cancer screening, and how do we improve colorectal cancer screening. Using our role as a public health institution, we were able to bring all of the partners together, all of the healthcare systems together to say, we're going to get to 80 by 2018. And let's see, and this was all the great work we did in data, et cetera, that actually got implemented within our communities because we had that broader reach as being an academic health center. But my favorite story is this story. So this is 3 rounds of data looking at improving colorectal cancer screening within these 27 clinics, white, yellow, and blue. You'll notice with each round over the course of a year, the screening rates went up. The reason this is my favorite slide to show you is this was the unexpected slide because this system was not part of our process. They basically said, oh, there's this great work going on in the state to make Nebraska healthier. We're not part of the work group, but we want to make it happen. So these 27 clinics came together and started to make it happen based on the best practices that we were already pushing out. So this was one of my favorite things about this process in the state. This is my favorite thing, and I think Sarah Shirley is supposed to be in the audience somewhere from Nebraska, but part of the work in Omaha was to say, wait, we're hearing you talk about accountable health communities, talk about making Nebraska the first accountable health state in the nation. Well, we want to step up. Live Well Omaha wants to step up and become the first accountable health community in Nebraska. And they did it. And this was independent of what was going on at the academic health center process, although we're obviously supporting them in their great work. But they laid out that 78% of all early mortality in their county was due to 4 chronic diseases associated with four health behaviors and associated with 9 socioeconomic factors. And so they've laid this out in this community. They've started these work groups around these socioeconomic factors and are taking a bottom-down, top-down approach to try to address health within their community. So this was just catalyzed by what was going on in this other effort to make Nebraska the healthiest state in the union. And hopefully what I just showed you about what's going on in Live Well Omaha directly reflects your work that you're doing right out of the practical playbook. All right, let me shift to the changing landscape of health and healthcare in the United States. Now, the biggest thing, obviously, is the Affordable Care, the American Health Care Act, and what those implications could be if that actually, some version of that becomes law. This shows you the various declines, not just in health, the public health agencies, but obviously in Medicare, where it would not grow as it currently does for an $800 million deficit, and potentially go out to block grants to the states. But to be honest with you, that's just an undercurrent of what is going on in health care in the United States, and the profound shift that you are actually witnessing right now as we think about, the access to data and patients actually asking, can I get my MRI someplace where it's cheaper at this point because of co-insurance? Many of you, if I ask for a raise of hand, how many got their flu shots at a Minute Clinic or a pharmacy or something along those lines? Many of you, right? The sort of decentralization of healthcare, technology, the human genome now is about $5,000 to $7,000 per person. In the next 5 to 10 years, that's going to be at about $100. So you could expect with your medical record, each and every person will actually have not only their genome, probably, but hopefully their transcriptome and their metabiolomic. Those oics always get me. But that's where we're going as we think about health. But the biggest shift actually has been in payment models and how payment models are now going from fee-for-service to value-based payment models. And I knew we were there because when I became a dean, I had the health center, our medical center, knocking on my door to say, hey, we want to talk about community health workers, and I want to decrease readmissions. I'm like, whoa, you're coming to me to give me money? That sounds great. So I knew that the approaches as we moved to these new payment models were working. And as many of you in this audience know, we've going away from the sustainable growth rate model with the new Medicaid and CHIP Reauthorization Act of 2016 to this new quality payment model that will involve some merit incentive program, will involve some alternate pay models, but about 600,000 physicians who take Medicare patients will now be moving into this system. Other insurers are sort of moving along as they do with whatever's going on with Medicare. And a lot of these new quality measures are going to make your life so much easier when you think about how am I going to improve care for patients and how am I going to improve care for community if we capitalize on these dramatic changes that are going on in our health system. And CMS has just released a new grant around pilots for looking at these health determinants and how if you address health determinants, you can improve care for patients. Like, oh, that took you long enough. But that's just Ali's editorial comment. But this is their questionnaire that in this model, everybody will get asked about housing instability, food insecurity, transportation needs, utility needs, and interpersonal safety. And then how do you link those individuals back to community providers who can address these issues? A lot of the work that you see going on every day in the practical playbook along these lines, but the big difference being about the financial incentives. So a lot of the projects that we talk about and hear about, they're funded by organizations, some NGOs, et cetera, but this is now going to be fundamental funding right out of health insurers to do the work that we're all very passionate about. And this is the, I think this is the final culmination, right? NIH loves to talk about precision medicine, right? I want to talk about something else, right? I want to talk about, and I'm not sure what the right term is, but it's a precision prevention medicine, so we can sort of keep that precision part in what we do. But if we can think of prevention, given the science, given the data, that we could almost individualize what prevention should look like for you in the audience, look like for you in the audience, and look like for you in the audience. And this is a nice example, and I'm not sure if there's anybody here from the Gessinger health system in Pennsylvania, but this was a nice example I saw in the paper a couple of weeks ago about a fresh food pharmacy. Again, funded in this case by grant dollars. I'd like to see it funded inherently out of the system itself. Obviously, they're supporting it to some extent, but essentially for their diabetic patients, you don't just get a prescription for your insulin and your metformin, you get a prescription and work with a dietitian and a cook, a chef, to say, this is what you need to get for food. And they provide you food and a plan on how to eat that food for you and your family. Because if you're going to get people to go, then I've got the little wavy yellow sign. But this is where we're going. And it's a nice convergence in time. So this slide is from 2 years ago, talking about how health care is moving from high-quality acute care to population-based outcomes. I sure hope everybody recognizes how this looks exactly like, how this looks exactly like this, right? Public health is going in the exact, what about this beautiful alignment of where healthcare and public health are going for what we need to be doing? And this makes Henry Ford's comment so true. If everyone is moving forward together, then success takes care of itself. Let me end, since I got my little wavy yellow sign on these 3 slides. So what's the secret sauce, right? The secret sauce to me, and people ask what keeps me up at night, and what keeps me up at night is these aligned financial incentives. Where are those dollars for us to do the work we want to do in public health and healthcare that's about our patients and about our communities? That isn't the traditional healthcare piece that is funded so well currently in the United States. And what that takes is these partnerships, backbone organizations, data, metrics, leadership, and practical evidence-based interventions. There's some examples of what that secret sauce happens to be for these great playbook examples. And let me leave you with a reminder of why we're all in this business, or why I'm in this business. I'm in this business when I see a slide like this that looks at life expectancy across the United States, and I go, how can this be in America to have this level of discrepancy in our counties across the United States? So that's why I'm in this business of public health. And I'm in this business of public health because of this lovely data from Glenn Mays from Kentucky. This is using Robert Wood Johnson data. I think this came out earlier what does it say? Last year, came out in April of last year. Great data, looking Robert Wood Johnson data over 20 years, large metropolitan community health center, community health departments representing 70% of the population, and they could show that with these multi-sector places that said they had stronger multi-sector collaborations, essentially public health social capital, they had marked declines in preventable causes of death, such as influenza, diabetes, and heart disease, and approached significance for cancer, and actually approached significance even for all-cause mortality at 0.08, if you believe in p-values as the all that matters in health. But this is where your work together leads to less costs and saved lives. Sounds like a great deal to me, to be honest with you. And what I'd like to see, if in an ideal world, is this. What I'd like to see is where we have the data for all costs in a community, we have the data for all outcomes, and people around this room working with their communities can come in for a census tract and say, I'm going to address obesity. That's going to save $100, and 50 of those dollars are mine to do that work, and our partners. And we will, and we are moving essentially to this place. And I hope that will take care of that final issue of aligned incentives. And I will leave you with your challenge as my last slide. This is your challenge. Okay. Okay, so I know that zipped along a little bit. I'll be glad to take questions. I have time for questions. And then obviously I'll be here for the rest of the day. I'm excited to hear these talks as much as you are and learn from you. So any questions, comments, suggestions? Please.
First of all, thank you very much. Your first slide was about the proposed budget, and then working to how we work together and how we need to save money. So how would you tell us to work in our communities if, in fact, any part of that budget that's proposed actually gets passed, which will actually cut funding for most of the things that you're asking us to do in our communities?
Don't you know the rule? You're supposed to ask the hard questions at the end? And
You can handle it.
the first question can't be the hardest question. So your challenge, one way your challenge is not changed, which is to help people understand what public health does in a community. But you now have the data to back up, and I think you have these fundamental transformational changes going on in the health system that are independent of this budget, that people want to save money in the health system. And we can show them that using public health, working with the community, we can save them money. And it wasn't a coincidence that I mentioned that the Nebraska Medicine came knocking on my door and said, we have this concern about readmissions because there's a penalty for readmissions for your patients if they're readmitted within a certain amount of time for certain disease conditions. And they want to talk about community health workers, and they want to fund me to train community health workers. I'm like, okay, if that's my business now, it's my business to work about competencies for community health workers. So I think it's there. It's sort of using these fundamental changes in the health systems with technology and payment and new metrics to leverage those to say, hi, I'm from your local health department. Public Health 3.0, I can help serve as a strategist for how we try to lower costs and improve quality within our communities. And the other thing I've learned, I'm from a deep blue state, and as I was telling Ed earlier, the head of legislative affairs at UNNC sweats bullets every time I go and talk. But I have learned over time how to make the economic argument about what it means for a community to be healthier and what that means for jobs in a community to be healthier. So that's sort of how I approach the same challenge every day. Additional question? Please.
Just looking at your last slide there, you asked us that question. I'd like to ask a smart person in the room that posed the question, what's your number one idea that you have?
On how to convince a butcher to tell people that fruits and vegetables are good. And I'll take you back to, and so I'll take you back to, this is my number one idea. Not my idea, but many people have had this idea. I think when we have true transparency, so all-cause payer in a census tract. We have true transparency on what health costs within a community, then we can better make the argument that we will help you with this cost if you're willing to share some of those dollars with me. I'm hoping that we may actually see some legislative proposals moving in those lines. I mean, the first thing that has to move is this issue of all-cause data, all-cause data within a community. And I think CDC or some other federal agency will be or should be tasked with this role of telling you how much health costs from all payers within a community. So if you have that all payer data, then I think the next step is a lot easier to say, well, okay, if you put Medicaid, Medicare, Blue Cross, Blue Shield, Aetna together, you're spending $100. Let me show you how you can cut some of that money. Because there's currently not that incentive, as you know.
Dr. Khan, I wonder if you could speak a moment to how you actually are working with the governmental public health enterprise from the local, state, and obviously the federal level.
So we actually have this is an advantage in our state, maybe being 1.8 million people, being the only accredited college of public health. When we have conversations, it's with our county health department and it's with our state health department. I have a very strong relationship with both of them, and the state actually, as they redid their state health improvement plan, looked at the national metrics around what makes a healthier state, and they essentially baked those into their I guess it's a SHIP, the State Health Improvement Plan. And so this is sort of how do you align all the efforts, and it's also baked into our CHIP, County Health Improvement Plan. So all of this work, how do you making sure it's all baked together and everybody is moving in the same direction? And so, you know, when I talked about colorectal cancer screening, they do a lot of colorectal cancer screening, and how did they make sure they aligned those efforts? The same thing with SBIRT. Our current project is actually to improve adolescent vaccinations, especially HPV vaccination, and so we're working with the state on how are we educating providers, how are we moving out vaccines to pharmacies and other venues that they don't traditionally use, and how do we make them available for VFC funding. So again, working directly with the county and state health department. And hopefully if somebody will find Sarah Soji, will talk about our Live Well. Shirley will talk about our Live Well Omaha efforts. She'll tell you how the Douglas County Health Department is central in that effort around accountable health community. The local health departments come with data. They come with a lot of strengths on why they are a central part of all of these coalitions. Dean.
Ali, how are you?
Fine, sir.
John Finnegan, I'm Dean of the School of Public Health at Minnesota, and I want to thank you, Ali, for the opportunity to purchase your school.
Or the other way around.
My cash flow isn't real good right now, so I think I'll forego that. But thank you for your talk, by the way. One thing, though, that you did raise by that sort of offhand remark is an issue, I think, about collaboration across colleges and schools of public health, in particular regions of the country. And as you probably are aware, we don't do as much of that as we should. The schools and programs of public health are dense on the East Coast and the West Coast, generally speaking. I don't know that they collaborate as much either. But in the Midwest, there's just a few of us. It just intrigues me, given that I think almost every state in the Midwest is facing almost exactly the same challenges that you outlined for Nebraska. We have these huge disparities that exist, and we frequently have this division between rural health and urban health, which we're also trying to divide. But I wonder maybe if you've given some thought to whether there is some kind of better collaboration that we could do in our part of the world. Maybe other regions of the country might look at that as well. We're all into cross-sectoral work, but perhaps we could even leverage that better if we had more of a regional focus as well as a local action.
That's really very thoughtful. And I think there are opportunities for us to think about how we can collaborate as schools of public health, especially in that part of the world. I tell people, maybe to shame them, that if you can't find a solution in Nebraska of 1.8 million people to make this the healthiest state in the union, how are you going to find that solution in New York or California or Texas? So I think there's a lot to teach the rest of the US, to be honest with you, in how you can think differently about health and what those collaborations look like, and more broadly at state and regional levels to find solutions. And maybe instead of an accountable health state, we can be talking one day about an accountable health region. Are we going to get to the easy questions?
I don't know. I'm Allison Ryan from Academy Health. You have a lot of great and rich data in these slides, and I'm curious to know, I mean, obviously these are data that we currently collect. What data do you feel like we don't collect that we need to move toward the vision that you've described?
So I think we need better data on cost. And I'm taking this from the perspective of coming from a red state to make that argument that to address obesity within a community, let me show you what money that's going to save you as a community that you currently put in to the insurers, to the state health department that pays Medicaid and Medicare reimbursements. So I think that type of data we don't have. So the types of studies I love is ones that show if you do Medicaid expansion in the state, what happens to improving, what happens to the bottom line. Where's the good data that says if Nebraska becomes the healthiest state in the union, I'm going to save X dollars? I don't have that data. I would love to be able to present that data for you. What's that data at the county level to say, you know what, if we look at the county health rankings, if we moved up 20 points on the county health ranking, or each point up on the county health ranking is this many dollars saved to the community or increase economic input to the community. So that piece of data, I think we lack. The other thing is we need to get a lot better at data integration. So how many people here are from state and local health departments? Okay, and how many people are from hospitals? A few. Okay, so you are dinosaurs. I'm sorry to tell you that. The asteroid has hit. It really has, and you just don't know it yet. Okay, and I say that for health because for hospitals, as you all know, I mean, they're instead of revenue generating, soon they will become cost centered. It's like, how do I keep patients out of a hospital no matter what happens? But the same thing for public health. And the way we used to do, for example, public health surveillance, does that make sense where somebody at the county would sort of fill out a form and fax it to somebody at the state local health department, would fax it to somebody at the state health department, would eventually fax it to somebody at CDC, would probably put it into something called DOS and try to figure out what the heck's going on with it. I'm being facetious. We've gotten a little better, but not much better. I still see spreadsheets flying around during outbreaks to try to figure out who's on the outbreak list. I'm like, really? With in Excel spreadsheets going from one state to the other to try to understand what's going on? And now we don't do good with the EHR integration. I mean, I think there's a whole layer of public health that's about to disappear and will be replaced by direct input directly from the EHR all the way up to understand what's going on in our communities. We still need public health, so that part's not going to go away. But the business of public health, I think, is going to dramatically change. It's already dramatically changing. So I don't think we do enough with that data integration back in our communities. I can tell you in my community, we still are trying to say, okay, what is the environmental data in our community around smog, et cetera? How am I connecting that to my clinical data about what's going on with asthma? How am I connecting that with some cost data and making the case within my community about what's going on and what we could do better if we, help some kids with asthma or decrease our smog levels? I don't think maybe some of you in this community do better with that, but we don't do very well with that good data integration now with the data that's available to us. Sir.
Thank you. You mentioned the issues that we have with data collection process. Now, I'm primarily on the IT side, and the challenges that we see, I mean, we love saying data is a four-letter bad word, right? Because we are so focused on not implementing processes to collect it correctly. For example, when you talk about public health, how do you actually take it down to the individual patient level or a community level? Because our systems are, like you said, extremely antiquated. Some of them collect information at the county level, some at the zip code level, some at various other combinations. Our systems are not designed or planned for in a way. So we are focused on the end user community, but we are not actually looking at how do we improve our data collection processes. And don't blame the IT guy if you're not able to actually see the stuff.
So that is super insightful, and that's not a data problem, right? That's a culture problem and political will problem. And this is why I see local health departments as that final boots on the ground where public health really happens. So when I was at CDC, I always, you get these young, bright people who show up, they've shown up at the Ivory Tower, and I tell them, never forget public health doesn't happen on 1600 Clifton Road. Public health happens in your communities. Okay, and it's that local health department. So we and many of you in this room, so we work with IBM Watson all the time, okay, to look at our EHR data, to essentially lay out treatment guidelines for patients, to say, okay, a cancer patient should be doing X, Y, and Z. There is no reason why the local health department working with their hospitals and providers can't have the data at their level, which you're talking about actionable level data, right? Actionable level data, right? There's no reason that local health department can't be the source of that actionable level data, working with their partners, nor the state health department working with their partners, as opposed to trying to reach out to a federal database to try to understand what the heck's going on in your community. Is that gets the gist of what you are? And that's essentially your local work within your communities, with your local information exchanges, et cetera, to try to get that set up. And the legislative process to do that. Policy underlies all of these conversations, as you know, right? And you need to be interacting with your legislators to make the necessary changes, to make those cultural changes about, we expect everybody to be in the information exchange. You can't opt out of this, right? And then how to then put that data together and then use it. Is that I'm done? Thank you, everybody.